And get rid of that. Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. We are live on the 2016 April 8th edition of Finally Friday. I don't know why I said the date backward. I want to thank you for choosing to spend your time with us here on Finally Friday. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. One of our partner firms is Recovery Analytics. That's Sharon Easterling's company. She does auditing and education, often authors articles for AHIMA as an AHIMA Fellow, and she is a co-host on the show. Finally Friday is also now sponsored by MedLink's Cost Containment, makers of the Healthcare Audit Tracker. Visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. Our newest sponsor is MAS Coding Solutions, a leading healthcare consulting firm with over 25 years in the medical coding industry, and they have core competencies in medical coding solutions and medical coding education. You can also see this conference, which I recommend you go take a look at because it has like 2-hour sessions about coding ICD-10 and auditing. There's a ton of great information on it, and that is run by MAS Coding Solutions. Anyway, there's a link where you can go look at it. I recommend you at least go take a look. Finally, we're also partnered with the Council for Certification of Medical Auditors, the CCMA. They are the creators of the widely used Certified Medical Audit Specialist Certification, or CMAS, and we're proud to have been approved to offer CEUs for our shows for all CMAS holders. You can find those CEU certificates on our This Week on Finally Friday page every week, and I'll show you that in a few minutes. And that's what, okay, I forgot I had that slide in there. All right. Today we are happy to have our special guest here to talk about why clinical documentation improvement programs are not delivering on the promise to improve documentation and claim success rates. But he's also going to talk about a suggestion for how to rethink CDI and finally deliver on its promise. Our guest is Glenn Krause, Director of Enterprise Solutions at ZerMed. Glenn's a huge advocate for CDI programs and often speaks on the topic all over the country. He's been working with Sharon Easterling recently on some of these talks, and they'll both be offering a free webinar hosted by Appeal Academy on all this soon. And if you want to hear more about what we're talking about today, then just watch for our emails and announcements about all that. That'll happen very shortly. Of course, I also have my loyal and faithful co-hosts on hand. Sharon, who, Bill's having trouble dialing in, and I'm trying to deal with that at the same time. Anyway, I have Sharon Easterling on hand. She is an auditor, speaker, writer, and appeal writer. And my other co-host, Bill Malm, a practicing clinician, speaker, a writer, certified medical auditor, and managing director of his own company, Health Revenue Integrity Services. Bill's actually calling in from the UK. That's what I'm trying to get cleared up here, where he's out there doing some work on population health management. So thanks to everyone for joining me. One thing I want to say before we get started, if you haven't figured it out by now, this is kind of an informal show and discussion group. I do want to make it clear that the opinions shared on this show are those of my panelists, not necessarily representative of their employers, and my opinions are my own and no one else's, especially not those of our sponsors. So now, before we get started, okay, Sharon, I'm going to ask you to can you text to Bill the correct code for getting into the
Sure.
247-08061?
Yeah,
And then you know the other stuff. I sent him the wrong one. So anyway, okay, well, like I said, we're informal around here. Okay, while she's doing that and we get Bill on the line, I want to switch over to the website to show you a little bit about the show in particular. If you are new to the show, what you want to do is, well, I highly encourage you to go listen to our theme song. That's under Fun Stuff on Appeal Academy. But if you are trying to figure out how to use the room, or you want more instruction on it, on every page on Appeal Academy, there's a box like this on the right side, a widget that takes you to this page if you click on it, and it gives you all the instructions you need for how to run the control panel in the Join.me room, which is what we use. The reason we use it is because, number one, it's affordable. Number two, it has a large number of seats available, has international numbers to call in, and also because it has a chat room, which is pretty active. Yeah, and see, somebody's already over there asking how you get audio, and somebody was nice enough to tell them. Okay, good. Bill, is that you?
Yeah, that's me.
Oh, okay, good, great, thanks. I'm sorry I got you the wrong numbers. Oh, well.
You did.
Okay. All right, so everyone, like I said, on that control room overview, you can see how to, you can connect by either phone or the internet. I recommend the phone. It's usually easier to use. There is a chat box. That's that second button from the left. You want to open that up because it's pretty active usually during our shows. You can zoom in and out on the page, but just be aware once you zoom in, it'll stay zoomed in unless you zoom it back out. There's a list of participants, and there you can identify yourself if you want to. If you're the one at the top of the list, you can see, if you open that list, you can see a lot of people do. It's okay because that box is not recorded. I record the presentation of the show, but I do not record, and nobody can see that box in the recording. So there's no record of that or who you are or what you say. I do ask, though, everybody, please keep in mind it's a public chat room. Please keep your comments appropriate and respectful. We have a lot of different kind of people in here with different kind of jobs. So, other options. No, I'm not going to give you control of the room. Okay. So let me get back to the last thing I want to tell you about is that under Finally Friday, this week on Finally Friday, it's the same page every week. Call-in numbers are the same. The link to get into the room is the same every week. But here's the information. I usually put it up sometime on Thursday or Friday at the latest, of course, saying what we're doing this week, and you can get an idea what the show is about. And if you scroll down, you can get the link. There's a button where you can enter the room directly. And I just changed this week the way you get handouts and watch the replays. I'm not asking you to put in your email anymore, and I think this will work easier because I had people telling me they couldn't get the downloads sometimes. So I think this will work easier. They're direct links, and I think that's going to be easier for everybody. Please let me know if you have trouble with that. You can email me or just let me know at the chat box. Usually people are really good about sending those PDFs to other people if you put your email in there. So, all right, that's enough of that. Okay, I think we're ready to go. Let me get back to the slides, and we will get cranking here. We got a lot to talk about today. I'm going to try to make sure we can get through all of it. So Glenn and I are going to be doing probably the first half of the show, and then about 35 minutes through, we'll get to Sharon. Bill, you can jump in any time. I know you've got plenty to say on the subject. Last week, we were talking about managed care anguish and how to deal with the audits that are going on there. So that's what you could see last week. This week, we're talking about how to make CDI deliver what it promised. It's not the fault of your CDI specialist. The trick is the program is not set up to deliver what it promises to do, what it has the promise of delivering, okay? So, but I don't want you to think it's impossible. You shouldn't think it's impossible, but even if you do, well, so what? Go after it. just like Cervantes said here. One must attempt the absurd sometimes to achieve the impossible, and that makes it all the better. Okay, a couple of news things before we get into the show. Sharon found this set of toolkits earlier this week that's all posted on CMS for free. Sharon, you want to chat just for a minute about what this stuff is and why people might want to get it?
Sure, Ernie. It's just some basic information for providers, physician-focused, hospital-focused. Most of the information is relevant to Medicaid. So I do find it interesting that they're creating the Medicaid toolkits, even with all the problems we're having with Medicaid, and that could be why. A great number of the toolkits have to do with fraud and abuse. So it's showing you how to protect yourself. There's information in there on self-auditing. It tells you how to do a self-audit. It talks about when you make discoveries in that audit, what the process should be going forward. Also, what I think is neat, if you want to do this, they're linked to videos. So there is someone from CMS on there walking through the PowerPoint, and they can give you some in-depth thinking of what's behind some of these toolkits. So just pretty interesting.
Wow, yeah, it's there's lots of videos like that out on the OIG website as well. Those are the kind of things you want to. We try to keep up on where they are and try to let everybody know about it when we find them. So it looks to me like most of these are about Medicaid, but they're probably still pretty useful for Medicare topics as well. Next week we are going to be talking about that. Yeah.
Yes, the Department of Program Integrity.
Yeah, okay. Yeah, and they cover both Medicare and Medicaid. Okay. We're going to talk about in a minute how next week Jessica Gustafson from the Health Law Partners is going to give us a legal review of the ins and outs of self-auditing and reporting all that, so I'll get to that in a minute. The other thing was thanks to Glenn Krause for bringing this to my attention this morning, that Northrop Grumman was just awarded a contract to develop the second version of the fraud prevention system, what CMS calls FPS2. So we're not going to have time to go over that today. I did write a little bit about it in my blog. It is on the Appeal Academy blog. It's the top post. This is a diagram that I found very interesting. It's kind of hard to see. They didn't post a very good resolution of it, but it is readable. The interesting thing to me was looking at this, and I was very interested that they did this. They put in here the Medicare beneficiaries. You see that down here in the corner? But it's not connected to anything. I think they put that in there just so they can tell Congress, oh yeah, we're paying attention to this is all because we're protecting Medicare beneficiaries, although they never study the effect of all these programs on the Medicare beneficiaries. That's been proven because of 1599 and 2 Midnight Rule. They never look at what it does to them. They just look at what it does to their numbers. And to me, it's another indication that that's what they're focused on. I'm not sure I blame them for that, but come on. Be genuine here. So anyway, that's an interesting model to look at and study, and we'll talk about it some more in the future. Last bit of news I want to mention, this was an article. I did put it up on the screen last week, but I wanted to let everybody know because we have probably a bunch of new people today on the show, which I've noticed, and I wanted to make sure that you get to see it. This is an article that Jessica Gustafson and Clinton Mickle from the Health Law Partners wrote and had published in the ABA Health Law section. So it's a very good article. It gives you a preview of what they're going to talk about next week. And look, her articles, the ones that Jessica writes, it usually has 40 or 50 references in it that are worth having if you have nothing else. If you didn't learn anything else, you're going to get 40 or 50 references to things all over the web that are important things to know in legal matters. So that's worth doing it. Okay, so this week what we're talking about is trying to tackle the impossible. Now, I say that because I know that people are going to think, well, probably, maybe not even all of you. I know not all of you, but Probably most of you are not directly involved in CDI. You're not CDI specialists, but you work with them. But it probably looks to you like it's an impossible task. What are you talking about? You want to redo the whole thing? Yes, I do. And that's what I want to talk about, but it's kind of fun. Now, there are things that are impossible in this world, okay? I could have come up with a lot of things that are impossible. You can't have cats and a plant at the same time. That's one thing that I know from personal experience you can't have. So that is impossible. Then I made a list of the top 5 things that I think are impossible. So here they are. Number 5, meaningful use will become meaningful and useful. Ain't going to happen, and according to Andy Slavitt, it's going away anyway, maybe. Bernie Sanders is never going to become a Democrat. Congress is never going to simplify the tax codes. Donald Trump will never exhibit humility in class. I think if he even said those 2 words, he would disintegrate on the spot. And number 1, CMS is never going to provide a clear definition of inpatient. It's just not in their DNA. So there are some things in the world that are impossible. But changing your CDI program is possible. It's kind of like going to IKEA. You may think you can't assemble a piece of furniture or create great things, but you can. IKEA proves that that's possible. However, you have to make sure that you follow the instructions, okay? I mean, how many of you done this, right? I've done this, bought something at IKEA, put it together, and it didn't come out right. You have to take it apart, start over, and try to read the instructions. And, you know, it reminds me of there are 5 stages of the grief associated with building a knockdown bed or building an EMR system. That's pretty close, and that should be near and dear to CDI programs, okay? So there are 5 stages. You know, stage 1, denial. You know, you think, oh, this is terrific. We're going to be able to do this. It's going to solve lots of problems. Stage 2 is anger, when you discover that Allen wrenches are from the devil. Then, you know, there's actually a lot more to that stage 2 anger. You know, you find things that just don't fit together no matter what you do with them. And then there's, you know, you want to bash them with a hammer. And doesn't this remind you of working with an EMR, right? And then you get to the bargaining stage where, you know, well, you want to pay somebody to find the person who created this and murder them. Stage 4 is when you just totally get depressed. You know, you thought this was going to be such a great solution for you, and it's turned out to be the greatest disaster in your life. And stage 5 is acceptance, where you finally just sleep on the box because you can't put the bed together. I don't know what acceptance looks like for an EMR, but I have a suspicion that it's not exactly the same thing, but probably pretty close. Maybe you're sleeping on a box. I don't know. There is a solution, though, to avoid all this grief, and that is to have a great set of instructions. So you got to know what you're doing. Now, IKEA really does have some pretty good instructions. Here's an example for building a Morocco chair. This is what their instruction sheet looks like. Now, put it in the chat box if you think you can identify it. What's the one thing on this page that shows that it's the one thing that contributes the most to the success of the assembly of this chair? Go ahead, put it in the chat box. So you got lots of diagrams, you got lots of, they're numbered, you've got an exploded view, you've got, it tells you how many parts you're supposed to have. No words, yeah. That's probably pretty helpful. Although I think that's just because they don't want to have to translate it all. Yeah, you don't have to read. It's a clear picture. There we are. Viewer 186 got it, and 139. A view of the final product. You know what the goal is when you start. That is the most important thing. The exploded view is how all these things are helpful, but the most important thing is you should know what it's going to look like when you get it done. You have to have the end in mind. You need to know that, okay? So that's why CDI fails, because it has no goal or it has the wrong goal. Okay, and I'm going to prove it to you here. Okay, that's what, you know, what happens with CDI is you get lots of unexpected events. How many of you have seen these ads from Hartford, the things that come from the warehouse of the unexpected, right? I don't have time to go into those. You can go on YouTube and look them up if you're as silly like I am and you want to see all of them. There's about 6 of the ads. They're 30 seconds ad. They crack me up. Anyway, you know, lots of unexpected things happen because you don't have the right goal set up, or you don't have any goals. Want proof? Here, ask yourself these questions. What does your CDI program focus on? Do you even know? And what are most of your denials about? Do you know that? Do your CDI program know that? Do your CDI specialists know that? Does anybody tell them? Does anybody even tell them they're supposed to know, or they should know, or what they should do with it? What do your payer auditors say about your claims when they issue denials? Do you talk to them? Have you ever heard them say what it is? Sharon and Bill, I know you can tell me the kind of things that you see all the time, whether it's for internal or external auditors. What do you guys say about the claims? Bill, I know you had plenty to say about this. What do you see in those claims?
Well, we see errors. They're one-off things. They're patterns of behaviors. But what usually happens is the CDI team is working on a specific claim or specific instance or specific diagnosis, and they're not involved. This doesn't feed back to them. They're not on the denial team. They're not in those key places where they really could bring a lot to the table.
Yeah, there's Stephanie making comment. Yeah, I don't think there was ever meant to be a connection between CDI and denials. But there should be. That's our whole point, okay? And does your CDI... Go ahead.
Ernie, I agree with Bill and what you're saying, Ernie, because I was doing a conference presentation about a couple of weeks ago, about 20 people in the room, and I asked how many of you get feedback from your denials and appeals department. Not one raised their hand. So I'm firm in the conviction that we certainly operate in a vacuum. We have our blinders on, and when we get a query answered, we think we accomplish what we need, and we move on to the next case.
Yeah, and here's some comments in the chat box. Dr. Field saying CDI should be about getting accurate medical info into the current record. Dollars fall where they go. Absolutely. And then viewer 200 says, but if the MD doesn't document why they are ordering tests, etc., then medical necessity cannot be proven. How many CDI programs focus on medical necessity? Anyone? Raise your hand. Bueller? They don't. Yeah, somebody's saying it's a silo again.
That's right. That's the problem with CDI. We have. I think we're going to move into this about goals, objectives, and missions. And our goals, objectives, and missions, even if they're not formal, unofficially, they don't contribute to a solid revenue cycle process. They
exactly.
They actually contribute to denials.
They're not really a part of it. What's their main focus usually these days? It's about getting the diagnosis right. Getting the most CCs and HCCs they can get. And that's a focus on reimbursement. That's a focus on money instead of on the patient, instead of on making sure. Now, you have to do something about the money because the record is how you get paid. That is the billing form. Whether anybody knows it, it's the medical record. It's not the 1500, it's not the UB04, it's the medical record. So that is something that has to be focused. So the trouble is nobody's talking to CDI about it, and they have the promise of dealing with all this. And there's somebody saying, they're saying, but isn't that a part of case management? Well, I don't think it's a part of case management, but I sure think it should be talking to case management. Absolutely should be talking. It shouldn't be aware of what do the PIPA reports say about your facility. What are the other scorecards? Do they see any scorecards? Right. Dr. Field has it exactly right. It is a team effort. That's our biggest point today. Look at this. This little continuum here. Where does CDI belong, and where is it in your process today? Where should it start? Where should it be involved? Where should it not be involved? Put into the chat box what you think. Where does CDI belong in your process? And that's it. There's lots. Okay, there's lots of. Of course, starts with the provider, comes active at first presentation. Absolutely, I totally agree. It needs to be something that happens right up front. But how many of your CDI programs are involved that far up front? I tend to think, from what I hear, but Glenn, you tell me, they get involved kind of after the stuff happens. They're not that often up there up front.
Yeah, well, I think we have a slide coming up about reactive and proactive, right, Ernie?
Yes, yeah.
Next slide.
We're going to talk about that in a minute. Yep.
Okay, so one of the if you look at most CDI programs, and we're getting some good responses in the chat box.
Yeah.
It starts that it's when the patient becomes inpatient. We don't necessarily need the CDI belongs really in the in the ED, and we have some CDI programs that are supposedly in the ED. What they're doing is looking at beginning the process of querying or looking at the diagnosis. They're not looking at the content and the context to support that medical necessity for the reason for admission. So that's one of the downfalls. So even if we do have some facilities using CDI in the ED, the intent and purpose is not really, to what I gather, to be really improving documentation the way it should be.
Yeah, and here's Stephanie saying, and I know she talks to a lot of programs. She says that they're not generally structured to determine medical necessity. Glenn's right, and I agree with Dr. Hirsch, who's saying that the problem is that CDI specialists don't provide patient care, so it's hard to get FTEs from the C-suite. They're too short-sighted about this. Well, we're going to talk about how you might be able to deal with that. Okay, so. Let's go on to the next slide. Now, here's some more questions to answer about your CDI program. Okay? What is the mission of your CDI program? Does it even have a mission? Is it got a mission statement? Where's it written down? Does anybody know it? Is it on a wall anywhere? Does anybody know what it is? Does the program have measurable goals and objectives beyond, getting the diagnosis right? Is your CDI team actively involved with other departments in revenue cycle management? Are they involved with anybody else except the physicians? Have you got scorecards created for, how the CDI program is doing, how they're moving towards their goals and objectives? If you don't have these things, look, I'm a process guy. I don't need to know about CDI to know whether or not your CDI program can succeed or not. If you can answer these questions for me, I can tell you whether or not you're going to succeed or fail. I don't care what it is they do. If you can't answer these questions about a CDI program, that program is not going to succeed. I don't care what it is. I got enough experience to know that just ain't going to happen. Go ahead.
Yeah, Ernie, one of the questions that's not on here is how do you measure? Well, I guess you do. You have your measurable goals and objectives. Unfortunately, how we measure the outcome of CDI is the CCMC capture rate and the DIG frequency report and the resulting case mix index. But the measurement should be focusing on how do we equate documentation improvement to the quality of the documentation in the chart. It's really the clinical content and context that supports the diagnoses, and our focus is too much on, obviously, key performance indicators of reimbursement focus, like number of queries, number responded, how many affect reimbursement, how many are principal diagnosis. So if you look at all the KPIs associated with CDI, they're all relevant to reimbursement, and I'm not saying reimbursement has to be, we must have reimbursement to support these programs. It shouldn't be the processed outcome. It should be a byproduct of our efforts to improve documentation and working with other members of our revenue cycle management team. So just the fact that we don't get feedback on our PEPA data, we don't see how we're creating potential compliance and this risk with our CCMC capture rate and DRG frequencies and pairs and one-day stays. We have the potential to really increase compliance risk and have a negative impact on the revenue cycle.
Yeah, and here's somebody saying, we had several people talking about how their CDI programs are often measured based on case mix index. That's the wrong thing to measure, folks.
And Ernie and I have been talking on that with Sharon and several other people, including Bill. And if you look at the case mix index, it's actually, to me, it's a gross picture as opposed to a net picture, to the extent that case mix index is only based on what you billed. It's not graded based on what we got reimbursed. So look at all the competing forces, such as a third contractor who didn't perhaps change the principal diagnosis, or we have third-party payer cost containment companies that take away a CC or change a diagnosis from aspiration pneumonia to simple pneumonia. So case mix index is not a very valid and reliable tool of return on investment for our CDI programs, because it's based on what we build. It's not based on what we got paid.
Yeah, so we're going to look at some things that you should be doing here in a minute. But the big question is, and this is the question that you've got to keep in mind: which would you prefer to have, a proactive program or a reactive program? Nobody gets in a boat wearing a life preserver. You don't get in a boat and put a life preserver around your waist, right? That's what you get thrown after you're already drowning. What you want is a life vest, something that will prevent you from drowning to begin with, okay? So you want something to help stop the possibility of drowning, rather than something that, oh, you're already drowning and we're going to try to save you, okay? So you got to be proactive. And, the greatest quote I could find about that is, an ounce of prevention is worth a pound of cure. That came from Ben Franklin, ladies and gentlemen. So, that's somebody that I respect. Although I know he did want to make the turkey the national bird, but I forgive him that. Anyway, so I do think he was a pretty wise man. Now, once you accept this idea that you want to move CDI to be a proactive program instead of a reactive program, which is what it mostly is today, it looks at the record and tries to make sure it's got the proper diagnosis and gets all the CCs and MCCs. To me, that is reactive. That is not proactive. And I agree totally with Dr. Meyerson here, putting in chat. CDI should start in physicians' minds. CDI programs are a crutch. There's no reason doctors can't learn to document properly. I agree, but they're going to need some help, and I actually think CDI program is the answer to that, and we're going to talk about that in a minute. One of the things, though, that you want to be aware of is when you start working on a program, trying to make it proactive instead of reactive, you've got to watch out for people who make false promises, okay? And so I had to put it up. There are some vendors that will talk to you about, and this goes right to what probably a CFO wants to hear. Boy, I'm going to grow your bottom line. I'm going to boost or increase or grow your reimbursements. This is no different than what the cigarette makers did back in the 50s when they started saying, oh, look, no, we don't cause cancer. We'll cure you. Are you kidding me? But this is real stuff, folks. You can go watch documentaries about how they did that. Well, listen, the Department of Justice takes a really dim view. If you are using a vendor who advertises and the reason you accepted them is because they said they were going to boost your bottom line, you're in trouble. You may not know it yet, but you're in trouble if you do that. Government considers that.
I agree, and you can even go to some of the vendors' websites and they'll say we guarantee an 8% increase in your case mix, and we'll still we'll continue until we get there. But that's not necessarily, as I said earlier, that's not necessarily net revenue, number one. And number two, there's no, I like what Dr. Meyerson was saying. We spend more time querying and worried about compliant queries, which I'm a firm advocate for, but we don't spend a lot of time sharing best practices of documentation. So once again, we're not working on the process, we're focusing on the outcome.
Yeah. And here's some comments in there. Yeah, to move CDI to be proactive, you have to throw out current CDI software, and somebody else saying that, well, you're going to have to get them involved in the creation of the EMR and all the templates there. Absolutely. We're going to talk about that in a minute. So good stuff. We're all going in the right direction here, okay? Now, in the interest of full disclosure, I'm telling you it's not impossible. It may be difficult for you to get these kind of changes made, because if you're going to create a new program, you're going to have to destroy the old one. And you might need that sword, the one I showed on the first slide today, the gal with the sword, okay, you might need that just for defense, but you might need it because you're going to be instituting a change or calling for a change. And the only way you're going to make that happen is if you can prove the value. Now, there's a handout today called Overcoming Resistance to Change. Everybody knows about resistance to change, right? People resist change all the time. Well, that's part of human nature. I know how you can use, and I teach you in that document. I'm probably going to do a webinar about it in the future, but you can just call me and talk to me about it. You can use resistance to change as your best ally for getting people to change, even though they don't want to, okay? So read that document and then give me a call or write to me if you want to know more. But that's absolutely fine. I use it all the time. I use it when I create these shows. I use it when I sell the services that I do, the marketing services I do. So I know it works, and I can help you with that. Anyway, if you want to go from proactive to reactive, here's what you have to do. And Glenn, we got about 5 minutes before I want to make sure we get to Sharon.
Yeah, go ahead. Yeah.
So
I think one of the whoops, my computer went to sleep. Hold on a minute.
Well, these are things that Glenn had brought up to us, and we've been talking about the last few days. So these next 2 slides are the steps that you need to do to go from proactive to reactive.
Right.
And then Sharon's going to talk about an actual way to do some of that. Go ahead.
Right. So, in the interest of time, I'm going to briefly go through these. So, after our conversation earlier in the week, Ernie, with Sharon and Bill, I actually reached out to several colleagues to ask, please send me your goals and objectives. And and about 10 people that I reached out to, not one had any formal established goals and objectives. So it's hard to imagine any program being successful if you don't know what your goals and objectives and outcomes are designed to be or intended to be.
And they got to be written down.
No one had any. And the other thing is, okay, what in your facility? And I always ask this question: what best practice standards of documentation are you comparing your efforts to improve documentation against? And no one has any best practice standards of what we're expecting in the chart. The only thing we're looking for is diagnoses. So my question is, how do we judge the effectiveness of what we're doing if we don't know where we're going? So in terms of measuring success, you have to have some type of benchmark standard. The other is controls. For instance, I can see a benchmark meaning reducing denials for medical necessity, because medical necessity is the foundation or the fundamentals that causes denials. It's not because the doctor doesn't know the patient needs to be in the hospital. It's the insufficiencies of documentation of what the doctor knew at the time the order was written. And the other thing is involvement of other teams. So we still operate in a silo. We don't get feedback from our denials so we can invoke continuous quality improvement in our documentation. We don't necessarily work with case management because, after all, they're looking at the same documentation we need, not just for reimbursement for medical necessity. We certainly don't get any feedback on denials and appeals, and most physicians, in my experience, would want to know, what can I do better to help improve the documentation so I'm not on the top of the list of denials? I know some facilities that provide the denial ratios and the actual counts and score physicians and put it on a report card. No, there's nothing better, there's nothing quicker than a physician being top on the list asking for help, and I know that personally. And what about coding and billing? Obviously, our diagnosis impacts coding and billing. If anything is denied or downcoded, are we notified so we can take action and not repeat the same mistake over and over again? And the last thing that comes to mind is working with our medical informatics, because if you go up to a physician and ask what's the biggest challenge, it's always going to be pretty much this record is the way the record is structured. It's hard for me to put down my thoughts on paper. There are certain fields in the chart that can be changed or modified to meet the needs of the physicians. If they find it easier to use, they're going to tend to document more effectively.
Right. Then you have to measure and assess and refocus. That's one that I stuck in there because this is a process, folks. It's iterative. It's something you start and you get going. You do not fire and forget. If you want to fire and forget, go get another industry. And it ain't going to work there either unless you just can't do fire and forget very often unless you're a soldier, okay?
So let me mention this really quickly, Ernie,
go ahead, Sharon.
Just to jump in really quickly. The return on investment is there. We just don't know it's there. We don't know it's a return on investment. because we're not tracking it the way we need to track it and associating it with the dollar amount of the claim. So for medical necessity, even for services, we have two types of medical necessity. You have medical necessity for a reason for the test, and you have medical necessity for services of level of care. If we start looking at those things and tracking them and putting them down to dollar amount, and then you can show your intervention in that and how you made an impact, then you're going to be able to show your return on investment. In your PFS department, you probably have tons of denials that are coming through for medical necessity for a service. Maybe the patient had a chemo drug and they're denying because of the chemo. Well, what you know as a CDI, if you get involved, you can correct those errors and you can reduce those denials, which is going to positively impact your facility. So we're just not having this conversation, and that's why we don't know where the return on investment is. But Bill and I talk about this all the time. It's there.
Yeah.
Good point, Sharon.
So all this stuff, basically means, and this is what I was talking about, the real bonus to making your CDI program work, and besides that, you got to change it anyway because of value-based payment systems, which Sharon's going to talk about in a minute. It may be the key to blowing up those silos. And here there's an example in the chat box. Wendy, I would love to talk to you. Please write to me at my email or leave me a note on Appeal Academy. I would love to talk to you about, because she says their denial nurse auditors are doing appeals. That do appeals are involved with their CDI and coding teams. They're providing feedback on denials, working together to review denials and determine if they're appealable. And she says that they just started it, but they are definitely seeing the importance. Wendy, I really want to talk to you and be able to share with people, some of what's going on for you, because it sounds like that's a very good model and a good start. And we really wanted to say, look, this is going to blow up silos. It has to, because you're going to be talking. You're going to have departments talking to each other. Your CDI program could be the answer to this, even if it's not making much change right now. Okay, that's a start. And imagine what that's going to do if you can break down some silos using the CDI team. I mean, they got the perfect reason to go talk to those other departments, right? So that's our suggestion. And then one thing that is starting. And this is Sharon and Glenn have been doing some talks recently for ACDIS chapters about all this, and now we're going to get to the part where Sharon talks about she has become a real expert. Well, she's an expert on just about everything, but she's focused lately. Yeah,
wicked good, right? Ernie, wicked.
Yeah, wicked good. And she's got mad skills. And she's starting to talk about ambulatory CDI, that it is emerging. So now, Sharon, I'm going to let you know. We don't have much time to talk about it today, but Glenn and Sharon are going to record a webinar soon. It's going to be free via Appeal Academy, so keep watching for it. There's a complete presentation on all this without me in the middle. And then also Sharon's going to do a webinar that is focused specifically on what she calls the building blocks of documentation, that has been also very well received. Again, these are free things. They give you an idea, some great ideas, and frankly, reasons that you should be talking to Glenn and to Sharon separately, outside of all this. Anyway, keep watching for that. All right, Sharon, I'm going to shut up now. We got about 15 minutes left. I think that should be enough time for you to get through most of this, even with all our discussion. So, Sharon.
Okay. Well, this is really a great time to be having this conversation. And Glenn's been having this conversation for a while now. I've seen him post things off and on. Bill and I talk about it. But because we're in the stage of healthcare transformation, and, Bill's over there working with population health management because wherever he is focused on being ready for the next level of healthcare. And your CDI can be a very important part of that transformation because they will help fill a lot of the pieces that are associated with that, because we're going to have to look at how we do things differently. So this is a great time to look at what you do with your CDI program and make some changes. So go to the next slide, Ernie.
Okay.
And that particular slide, I think, that was a survey done by Advisory Board, and I know Actis has done a survey as well, but they said 22% of the participants on the survey were looking at starting an ambulatory or outpatient CDI program in the next 12 months. Well, that's key, and those folks are being progressive. So are you having that conversation within your facility about what you're going to do for outpatient? Because to achieve that goal of total healthcare transformation and population health management, CDI is going to have to touch every entry point of your hospital. And I say entry point because it needs to start at the very beginning, and we haven't been doing that. So this particular slide here, it talks about what some of the components are in your billing process where CDI could possibly have an impact, or what is impacted by payment. So we have diagnoses for ICD-10. There's payment impact there and quality impact. We have procedures, which are paid from CPT codes and E&M levels. And then we have quality. And quality is affected by your diagnoses, it's affected by your CPT code, and it's affected by your clinical treatment and your medications, whatever services you're performing for those patients. So those are three key things that you need to be thinking about for your facility. Okay, do I have my diagnosis covered for inpatient and outpatient? Probably not. Most of us have just been focused on inpatient. Are we looking at CPT at all? The reason I have CPT here, I-10 PCS is also a component of that, is because we haven't thought and talked a lot about CPT when it comes to CDI. But that is another very important part that we need to focus on. And, of course, the clinical treatment, key piece for CDI, because I've seen some great remarks in this chat box. The chat box is booming today, by the way. But yeah, the clinical treatment is really what is going to, it is the foundation for why we're even doing CDI, to help get that documentation outside of the documentation. It is the foundation. Okay, Ernie.
Okay. Oops. My mouse keeps hiding because I'm in the chat box. Okay.
So, we're looking at transforming CDI. And when you look at transforming CDI, what do you need to do? Well, you need to self-evaluate. You need to look at key things, and we're going to look at what those key things are, so you can determine where you are and where you're going and where you want to be. And I call this the C process, CDIC. We want to see what our CDI process is currently going to be. And this particular chart here, this is a graph. This is CDIC. And this is a process that you can use to self-evaluate and transform yourself within your institution to be better prepared for the changing healthcare environment. So one thing, and Glenn said he reached out to some folks. Some folks didn't even have a mission or goals, or they didn't know what they were going to achieve. Wow. So that means that you got this CDI process at your hospital where you're focusing on MC and CCs, and you're doing the regular CDI metrics that you think everybody else is doing, but you're really not having a focus for your facility. Maybe you ran a report and you know what your top 20 DRGs are, or maybe you know that you have an ICU, you have an intermediate care, and you have a critical care, and you're just going to focus on those three areas of your department. But think out of the box here. Think about, for your system or hospital, for this healthcare transformation, what's your mission going to be? Do you want to be able to achieve higher quality scores? Are you looking at your mortality rate? Are you trying to, as Glenn is saying, improve your documentation for physician X? And if you are doing that, are you tracking it and trending it? But definitely have a mission that is overall of what you want to achieve. You want CDI to impact population health management for this facility by X for blank. That's kind of that's more of a goal, but the mission is the broad picture. So to achieve a mission, you need to do an assessment of yourself. Now, there are a couple of ways you can do assessments. You can do assessments from a pre-bill standpoint, or you can do it from a post-bill standpoint. And when I talk about assessments, I mean taking some charts or some encounters, looking at them closely, and assessing what those deficiencies are. Establish yourself a target and a direction, and just kind of look at your sample of charts and say, okay, I looked at 20 inpatient records. Let's say HCCs is kind of what you want to focus on, and we're only reporting 20% of our hierarchical condition categories, but we want to be able to report 60% of those. Look at yourself a little closer. Set your goals off of that, and that was just a goal I stated. You know, what do you want to achieve in this? What do you want to be able to track? What do you want to be able to show your CFO or your CEO or your board, where you can do yourself a nice scorecard and you can say, okay, these are our goals for the year, and this is where we are month to month to month. So you can see the progress, and they can see this is making impact. And if possible, you can tie numbers to that financially. Now, to be able to achieve this, you continually have to look at, and I'm going to skip that identifying opportunity, but you're going to have to look at assessing your staffing. And that is a key piece of your CDI program. Because for healthcare transformation, and we're talking about looking at ambulatory outside of the norm of inpatient, who's going to do that? Do you have those key people? Do you need more training? Do you need more education? Is your physician advisor going to have to get more education? What do you lay out for who needs to do this critical piece? The next piece of that is the education. After you decide who you want to have, what kind of background you want them to have, then you need to say, okay, they're deficient here. How do we get them better educated to be able to attack this? Do we need to get them HCC training? Do they need some CPT training? Do they need some training in quality? Do they need to better understand PSS and HACs? Look at it from that way after you set your focus, and then educate and move forward and start with implementation or re-implementation.
And Sharon, I just wanted to pop in here. I wanted to pop in here. This slide with all these different rings is very similar to Six Sigma with the define, measure, analyze, implement, and control. Many of these steps are very similar to DMAIC. So it's a process that should be going on now in most hospitals, but I don't always see it occurring. I see them more still flying by the seat of their pants.
Yeah, absolutely, Bill.
Okay, so then there's the mission, what you're saying about, the program mission and how you define that.
Yeah, and as I was saying, you have the pre-assessment piece, and that's where you identify what your areas of opportunities are, or you kind of know that already. You kind of know where your deficiencies are within your organization. I saw someone mentioning, no, we don't look at denials at all. So that might be something you need to focus on for your facility, and then know what you want to accomplish from that. And then you have your post-assessment, and that's where you're looking at things after the claim has been dropped or after the patient's been discharged. And from there, you're also going to look at opportunities that you could have made a different impact for that particular visit. And then you're going to determine, okay, these are things that we know we could have done better. We weren't capturing these HCC diagnoses. Here we have a patient. They had a gastric bypass 10 years ago. Well, we won't say 10 years ago, 5 years ago. He still has an ostomy status, and now he's in the hospital for a complication of an ostomy. Well, we never reported that ostomy status code. So, therefore, we weren't showing the severity of those patients. So once you start drilling down and looking at those things a little closer, you're going to be able to identify what you can track, what you can trend to make an impact.
Yep.
And you can go to the next slide.
Okay. Here we go.
Now, here's an example of pre-assessment and post-assessment. And for pre-assessment, this is your, awareness stage. This is where you're kind of knowing what's happening already within your organization. So you got some poor quality scores out there. Your hospital compare data doesn't look very good. And you want to make an impact for that for next year. You might already know that your physician profiling is suboptimal. You have a number of physicians, they don't look really good publicly. You want to address that, and you want to see how you can make those scores look better. You might have a particular set of denials by contractor. You want to reduce those denials by the contractor. And, of course, you might want to prepare for payment change with HCCs. So those are things that you could do in the pre-assessment because you already know you have these problems, and these are things you want to fix. But for the post-assessment, that's where you're looking at things on the back end. You're going back and drilling down after the claim has been billed or maybe after discharge, and you're saying, wow, we got a high percentage of unspecified code usage here. Are you tracking that? Do you have a report on that already? If not, that might be something you want to address. We have a low-risk assessment scores for coding. That means that your HCC score percentages are low. Do we need to do something about that? Documentation does not support medical necessity or the reason for the test. We're having lots of issues right now with medical necessity. Some of that is the payer issue, where they don't have the appropriate code to be able to get it to the payer. But providers are still struggling with medical necessity for orders, having a diagnosis that is sufficient to be able to order the test. And, of course, underreported HCC codes. So those are some ideas of things that are outside of the box. Because, remember, we're at transformation. So that means we're going to a different stage. We're looking at ourselves differently. We're seeing ourselves so we can move forward for population health management.
And if I can throw in, this pre-assessment and post-assessment, the same process can be initiated on the inpatient side. And we touched briefly about CDI and physician advisor education. I from the CDI standpoint, I see plenty of opportunity to kind of re-educate ourselves on what is a good note, what is a good H&P, because if we don't have a good appreciation, understanding, and skill sets, and understanding when something is insufficient, it's going to be hard to identify and improve them. And if we don't have that skill set, we're never going to change what we're doing for CDI.
Well, absolutely, Glenn, especially with 10 right now, because 10, we're doing a lot of coding or things that we're not, what's this going to look like? This assessment phase can help us with 10 and narrow our focus on the inpatient side. I do agree, Glenn. So then after you kind of done your assessments and you either know where you want to go, you look at, okay, is this something that's driven by diagnoses or is this something that's driven by CPT code? And we can just stick PCS in there if you want to address this for inpatient, but what is this focused on? What's the driver behind it? And then you can move forward into how you want to tackle that from a process standpoint. Next slide, Ernie.
Okay.
And these are just some blurbs out of the webinar we're doing free. I think I addressed those a little differently in that webinar, so hopefully you'll be able to participate in that. But this is just some of the key slides from that presentation that I thought would be beneficial to do today. This particular slide here I won't spend any time on. This is the staffing model. So currently, we have nurses in a lot of places, or we have coders that are doing CDI, or is it a hybrid model where you're using both? Well, that's a part of the decision of restructuring or transforming your program. Do you want to have that hybrid? Our coder's going to be more beneficial in that. Our nurse is going to be. How are you going to handle that? Look at the background. What is this a focus for? Is it inpatient, outpatient? Are we looking at CPT? Are we looking at billing? And then potential growth for your CDI. We always want to grow as professionals. So what else do they need to be able to better do their job for healthcare transformation? Next slide, Ernie.
Yeah.
And I got critical thinking as a must on here, because if you can't critical think, that's just not – a CDI needs to be able to critical think. And we're talking about some real out-of-the-box stuff here. Someone that is flexible and can think through next stage. What were you going to say, Ernie?
Speaking of out of the box, this is my suggestion for what a successful team is made up of. When I've worked for large corporations, this is generally what I found to be successful teams are made up like. I was usually the Pedro Gonzalez in the room because my last name is De Los Santos. But I always had people like this. So there was always a Jenny, but I never knew what she did. Anyway, so that was my suggestion in all this. That you got to have a diverse team, and that way you can have critical thinking. You're going to have, if everybody is thinking the same thing, then nobody's thinking. Okay, so get a bunch of different people, get all those different kinds in the room so you can have different thinking. That's my contribution. Okay, I'll go back to Sharon's slides now.
Oh, gosh. And this is just more about education, Ernie. Not going to spend a lot of time because I'm already late for a phone call.
Okay.
But definitely, look at your staff. Does your physician advisor need education? How are you going to educate your physicians in doing all this?
Yeah. And then implementing it all, you've got to put all that in. Process, querying, tracking, reporting, and then, okay, so I'm trying to get through them. We got this sample initiative that you came up with. And again, folks, we're going to talk about, Sharon's going to go over all of this in her webinar soon. So you can look at the slides, and I know she's got to go. So, but, here's an example. Here's an example of how you do the physical exam.
Yeah, just to speak to this really quickly, Ernie, I've been involved with some ambulatory CDI projects, just trying to get them started. And for ambulatory CDI, and this is with a medical group, so you can actually work with your physicians in the medical group at the point the patient comes in, prior to kind of looking at the patient encounters, because if we're talking HCCs and we're talking about you're in a risk-based band, which could be a Medicare Advantage plan, you're looking at that patient's data for that entire year. So if I see they got diabetes and they had a visit for that some time ago, and I see they have acute renal failure and they had a visit for that some time ago, when they come in for their annual physical exam, the physician can address those things. But guess what? He can also apply a higher condition category to that, because that patient's going to have diabetes with renal failure. Now, in the documentation, and that's key. Now, I know ICD-10 lends us to some better things as far as how we're assigning those codes now, but the documentation has to be in the chart. And that's where CDI is important, because I'm very fearful now that with the EHR and our physicians are coding in the medical group, we may not have sufficient documentation to support the code that we've submitted. So I think there's a potential vulnerability there.
And I think a lot of times, Sharon, those templates and what have you in the EHR, they over-document senseless stuff that's not relevant. So sometimes the templates need to be adjusted so that you get the relevant points to get those things in for your CDI.
Right. And this is the objectives that are going to be in that webinar that Sharon's going to do about ambulatory CDI. So keep watching for that. And Sharon, I know you've got to go. You did terrific cramming all that in the 15 minutes I gave you there. But we will she'll have a whole hour to talk about it, and she and Glenn are going to do that one, about CDI in general. So be watching for that, folks. that's all the time we have today. We are continuing our Operation Rethink, basically focusing a lot more on outpatient than we did last year. We seem to be all focused on inpatient. Next week, though, we do have that special presentation by Jessica Gustafson about how to deal with the self-reporting final rule. And we have some case studies coming up, and then the building blocks of documentation. Sharon will do a show about it, and then a whole webinar. So we have all these things coming up. So thanks to everybody. I mean, that's all we got time for today. Like I said, we'll be back next Friday the 15th. Mark your calendar now. Bring your questions for Jessica if you have any questions about that, and watch for my announcements. Special thanks to Glenn for sharing his knowledge and experience with us today and the impetus to get this show. And then thanks to everybody who participated in the chat box today. Great job, everyone. And there's lots of, contact people in there. Let me know if you want to talk to somebody. Special thanks to, of course, Sharon and Bill for their help. Bill calling in all the way from the UK. So, and of course, we want to thank our sponsors and partners, HealthWell Partners, MedLink's Cost Containment, Mass Coding Solutions, Recovery Analytics, and the CCMA. It's their contributions to these broadcasts that make everything possible. So watch for my emails about April 15. Please share the links to our show with your colleagues and friends. And the last thing I want to share with you is this one thing that I think was uttered by a very wise man by the name of Albert Einstein. He said, a clever person solves a problem, but it's a wise person who avoids it. That's what we're talking about, folks. Get out in front of all these problems. Get rid of them beforehand so you don't have to deal with them on the back end. Anyway, that's all we got for today. We'll see you next time when it's finally Friday. Have a great weekend. Bye-bye. If any of you are still on the phone, we could talk, but you're probably not.